hopefully you guys got a chance to go vote today and everything, regardless of your political leanings and stuff. And I'm not ever going to look to get into debates in the class, but um, I do always advocate for voting. If you have any opportunity to do so, I would implore it, now, obviously, and in the future as well. Um, Even if obviously we don't agree, that's one of the best things about being an American and being able to do that. There's countries that vote, but they're all basically staged, and thankfully that's not how it is here. Your vote, if you, especially if you live in a battleground state, it actually matters. So I reckon, I always try to put that out there when the time comes, because you really can't complain about who's in office if you didn't vote in the first place. But anyway, um, hopefully you guys got an opportunity to. If you didn't, and your polls are still open, then what are you even doing here? Go vote. But for those of us that have voted, or if you do choose not to, that's obviously your right as well. We're going to talk about toxicology tonight. This chapter is surprisingly long in at least the slides. It's really not that bad when we're talking about like the subject matter. It should go pretty quick. So the slides I may be moving through slides pretty quickly, but that's because I don't know why we have over 100 slides for toxicology. That's just kind of mind blowing, to be honest with you. But anyway, let's get things going. Start this. There we go. All right. So when we talk about toxicology, what's the first thing that comes to mind? Absolute first thing. Somebody's going to overdose or have some kind of toxin in them. What's the first thing that comes to mind? Okay, so you go straight to what we would typically give, right? Narcan, charcoal, depending on what the issue is. But that's kind of what I was looking at. Our first go-to when we think about toxicology is usually, what did this person purposely do to themselves that they overdid, right? And we usually think about the overdosing, we think about drunks, we think all these things, and that's to be expected, right? That's real world stuff, and we are going to absolutely run into those people. In fact, depending on where you live, you may run into them a lot more often than other people. But it's everywhere. There's no location that is not inhabited by some sort of substance abuse portion of the population, or somebody that's susceptible to that, and it really doesn't know a economical range either, so, or a financial range. So we think poor people will do something, well, rich people will too, they just may do something different. Everybody has their vices. Usually it's perfectly fine. There's a lot of stuff out there that's perfectly legal, and there's nothing wrong with that, unless you drink you're way too much, or you smoke or whatever. What drug is it and how much of it they took, right? But there's a lot of other ones that are out there too. We're going to talk about that. Some toxins, some overdoses and stuff. Your patient really may not have had any control over. It might have been a completely accidental overdose with their medication. It could have been something environmental that they inhaled. We're going to talk about carbon monoxide poisoning, talk about snake bites, things like that, where it's not necessarily an allergic reaction, because we talked about in the previous class, a bee sting and a snake bite, those are toxins. Those are designed to give you the symptoms that you've got. That's not an allergic reaction. So those typically fall into this night's chapter. Um, but yes, some of it is self-induced, and it is what it is. So we just you have to be prepared for it, because you will come into contact with that. Almost any substance may be poison in certain circumstances. It may be something that's normally benign, but if it goes bad, it could be poisonous. So, anybody ever look at your medication and realize you have expiration dates on it? There's a reason. Sometimes some of the ingredients may go bad. Your own food, something you cook for dinner, if you don't cook it properly, you wind up with salmonella, or E. coli. Jesus, Hep A can come from bad meat. So that's coming from toxins. Acute poisoning affects 2 million people per year. Chronic poisoning is more common. In other words, you were exposed to it a little bit over a long period of time. Not necessarily something that hit you hard and fast, like say a snake bite or anything like that. Deaths caused by poisoning are fairly rare. Usually they suffer from the effects of it, but dying from it's not really that common. And again, we're talking about overall poisoning, right? Deaths from morphine overdose typically might kill you. Same with fentanyl. But when you think about all the different types of poisonings that are out there, to die from it's actually pretty rare. Rates of death as a result of poisoning in children have decreased steadily since the 60s due to child-resistant caps, which is fantastic. Think about your bleach, right? You can't just pop the bleach cap off as easily as you used to be able to. You have to kind of press down and twist, and it actually takes a little bit of elbow grease sometimes to do that. That's designed to keep kids out of it. So as long as mom and dad or grandparents or whoever is being careful about leaving bleach capped or put away, as an example, then usually that's not that big of an issue. But it does still happen through complacency or just straight up accidents. How many Tide Pods I ate? Hey, I'm a fan of the orange flavor, personally. Deaths caused by chronic poisoning in adults have been rising as a result of drug abuse. That's usually what's getting people these days. And that can be from a couple of things. Again, we talk about some people may use drugs as an escape. Some people use it as just something fun, like going out for drinks on a Saturday night. Some people are like, "Well, I'm just going to snort the outline of the United States and Coke as my Saturday night," and it doesn't always work out in their favor. A buddy of mine, who will remain nameless, um, currently is fighting. Well, I say he's fighting. He currently has. He's not fighting it. I'm trying to get him to fight it. A meth addiction, and it's not because he's looking for an escape. It's not because he's got nothing better to do. It's because he started his own company and he's gotten so busy that he has no time to sleep. And so he started using that to stay awake, and now he's kind of stuck on it. So I'm trying very hard to get him to realize what he's doing and to get him off of it, because that's not him. Um, Even though he's always been kind of a partier. So toxins can have acute or chronic effects. Substance abuse is the misuse of any substance to produce a desired effect. A common complication of substance abuse is overdose. And when a patient takes a toxic dose of the substance, is basically what that is. It's because you've gotten more. There are things out there that we are supposed to take. Like, well, I say not in general, but say if you got chronic back pain or you were in a bad accident, you may be prescribed the fentanyl or tabs or the OxyContin, the Percocets, blah blah blah. All these things are actually designed that we made them to be taken by people who need them. The problem comes in when they start getting taken in ways different than what they were prescribed. Your primary responsibility is to the patient. Um, and the biggest thing that you can do is to recognize that a poisoning has occurred. So for your own safety, if this is what you're dealing with, pay attention to your surroundings. You could become exposed to the same substance. If they got bit by a snake, the snake probably ran off. They got stung by a bunch of wasps and hornets. Those pissed off buggers are probably still floating around. Um, and you show up, and they're going to come after you too, because for whatever reason their territory got invaded or whatever. Um, Very small amounts of some poisons can cause considerable damage or death. If anybody has gone through a hazmat class, that you'll understand that, right? We talk about LD50 and LC50. LD is lethal dose, LC is lethal concentration, and then the 50 means 50%. So in a controlled laboratory, they inject X amount of these substances into, like, say, rats or whatever. And at the point that 50% of them die, whatever that dose was, that's what's considered the lethal dose. So all it has to do is have a 1 in 2 chance of killing you, and that's considered lethal dose. Doesn't mean you're going to die from it, but you got a 50% chance, and that's not in your favor. Um, If you suspect that ingestion or exposure to a toxic substance has occurred, notify med control and begin emergency treatment at once as soon as you know that you can get to the patient. Again, scene safety is huge on this because depending on what the problem is, you may not be able to get there safely. The signs and symptoms of poisoning vary according to the specific agent. Presence of injuries at a person's mouth strongly suggests the ingestion of a swallowed poison. That's an example. If you see, tire tracks or tread marks or whatever you want to call it, where they've been injecting things into them with needles, there's your sign of how they got their overdose. These are things that you're going to look for, especially when you're doing your head to toe assessment. We'll talk about that later. All right. So if possible, when you get your sample, ask your patient if they're alert. What did you take? When did you take it? That's important, especially if your agency still tries to use activated charcoal. Knowing when they took it means you may or may not be able to get some kind of benefit from using that. It's also good to know because when they get to the hospital, even if activated charcoal is not going to catch up to it, they may still be able to pump the stomach or give some kind of antagonist or agonist, depending on what it is, that will counteract that issue. How much did you ingest? Did you have anything to eat or drink? Why is that important? Why do we want to know if anybody had a steak with their, bottle full of Percocets? Empty stomach, ulcers, right? Right. So they could have the complication of ulcers. Um, and yeah, it's a couple of reasons. You're both right. Um, Empty stomach. If there's nothing in the stomach, that medication that they took is going to be less buffered and blended out as it goes through the portal circulation. Whereas if you put it with food, um, sometimes the food will absorb some of it as it's being digested, and then it doesn't get into the bloodstream as fast as if it were just that toxin. Has anyone given you an antidote or any substance orally since you ingested it? How much do you weigh? And that's another thing too. So, and I won't ask you all this one, but I'll go ahead and tell you. One of the things that matters, and if anybody here is we'll say a moderate to heavy drinker, um, you understand that body weight plays a factor in how long it takes you to get drunk. Now, it's not an exact science, but the bigger you are, usually the more alcohol you can handle. Um, because what will happen is your body will store what it can't digest in your fat until it can digest it. So, like alcohol, for example, the liver can only process so much at a time. So if you constantly are drinking, if you're an alcoholic or anything like that, and you're drinking every day, what will happen is eventually you're going to start to store those alcohol molecules in your fat until your portal circulation can pull it out and process it. And so the bigger you are, the more you can hold. Which in a toxin point of view, the good thing about that is the bigger you are, the less likely that medication will continue to circulate in your blood. It's going to get into your fat. It's going to stay there. You may have some watered down effects of that toxin, but at the same time, you may wind up being under the effect of that toxin for longer because your body's holding on to it. So that's another good question you can ask. Try to determine the nature of the poison. Look around the immediate area for any overturned bottles, needles, syringes, anything in your environment around the room that might give you something that it could be. But just don't pigeonhole it. For example, we responded to right about 4:45, 4:30, 4:45 one afternoon. We responded to a house with about 5 kids. I say kids, teenagers, all unconscious in the living room. Um, Parent came home, saw them all passed out in the living room, called 911. So we get there and we're looking around. We're thinking, okay, what could be causing this? And we see all kinds of paraphernalia around the tables. They'd all been smoking weed and stuff like that. So the first thought was, okay, they must have got a hold of some bad stuff, and now they're all passed out, and we're dealing with that. Um, the problem is through the course of the call, we started feeling bad, and we're not smoking. Come to find out, the weed was not anything to do. It just happened to be on the scene. But that wasn't their problem. The problem was carbon monoxide. They didn't realize it because they'd been smoking. So when they started feeling bad, they didn't think anything of it. They just thought that was part of the high. And then by the time they realized maybe they shouldn't be in the room, it was too late. They were already passing out. So around about the time me and my partner are starting to feel like we're going to throw up, we're like, okay, maybe this is something else. And we brought in the monitors. Turned out the carbon monoxide was through the roof. Um, so look for these things, but don't let the first time you see it, don't let that be like, oh, they must have been messed up on drugs, or that's not always the case. It might not have even been their weed. We don't know. We weren't there when they were smoking it. You find somebody unconscious in a room with alcohol laying around doesn't mean it's their alcohol. So anyway, I digress. Place any suspicious materials in a plastic bag and take it with you. All right. So if you're not sure, take it with you. That being said, um, I would be careful with that. Maybe call your supervisor, call your med director or something, and ask them if they absolutely need it, if it happens to be something that's a controlled substance like marijuana, um, just in case. Containers at the scene can provide critical information such as name and concentration of the drug, ingredients, number of pills originally in the bottle. If you ever look at the label, especially on something that's a controlled substance, it'll a lot of times it'll tell you how many pills are there and when it was filled, how many is in the bottle, and how many times they should take it. Therefore, or so you can do the math and be like, all right, well, there's supposed to be 100 pills in this bottle, and I've got 10. It's supposed to take one a day, and he got it filled 5 days ago. So you should have 95 pills in the bottle still. That kind of thing. Name of the manufacturer, which if you watch the news, you know that um, manufacturers are getting hemmed up all the time for finding carcinogens in their stuff. I think metformin recently got a bad rep because if they found carcinogens in it. But anyway, and then the prescribed dose. If the patient vomits, examine the contents for pill fragments just in case that's what the problem was. Wear your proper PPE and note and document anything that you see. Sometimes these turn into crime scenes, so you need to be thorough. All right, so real quick, how poisons enter the body. Emergency is going to be pretty much just like how medicine enters the body. All right, so think back to that chapter. Emergency care for a patient who has been poisoned may include actions that range from just reassuring an anxious patient to full-on CPR. Most of the time, you won't be administering a specific antidote. A lot of times, a hospital will do that, and it's because we just don't carry it. Right? There's no way. There's so many different things out there that it could be that it makes no sense to try to put everything on the ambulance. Not to mention some of that, or a lot of that, actually is climate controlled, which means that you may have to put a fridge on the ambulance, and you don't have a lot of real estate. The medication antidote most commonly carried by you, however, is going to be Narcan. With the opioid crisis that we've been in forever, it seems like, especially in your more well, I don't even say any more rural. It's not really the case. Same with urban, but you find more often than not that a lot of times if somebody's going to be overdosing on something, it winds up being some kind of opioid, and that's because the easiest thing to get your hands on is something that was originally given legally, right? I mean, it's kind of hard to get your hands on cocaine, but if your grandmother is on OxyContin or Percocets, fentanyl, and that kind of stuff, you can get your hands on that pretty easy because they got it just sitting around the house. Uh, so that's what we see the most. The medication, well, I already said that. Definitive treatment can only be provided at the ER. Narcan is not going to fix your patient. It's a lot like an EpiPen. For the duration that it's in their system, it will interfere with the opioid's ability to affect the body. However, it will wear off. And then if they still have that much fentanyl or whatever it is in their system, they're going to fall back into it. As EMTs, and well, I'll just say medical practitioners in general, your goal is not to wake your patient up when we deal with Narcan. All right, your goal is respiratory support. We want to keep them breathing. As they go further and further into an opioid induced coma, they're going to start to lose their respiratory drive, and that's what we don't want, because that's going to mean doing CPR on the way to the hospital. And I ain't gonna lie to you, I work out. If I don't want to do CPR if I don't have to. I get all my fun in the gym, and I'm lazy otherwise. But if I can keep them breathing with some Narcan, then fantastic. But I'm not a cop and I'm not a UFC fighter. I don't want to wake them up and then start throwing hands all the way to the hospital either. Um, so find that middle ground where they're breathing good, but they're still passed out, and that's going to be an easy day for you. There's actually a video on YouTube of a guy, I think he was in Florida, where he he was a good Samaritan, saw somebody passed out on the street, had some Narcan, went and gave it to him, and the guy woke up all pissed off because his high was ruined. Um, had no concept of the fact that he was about to die and that this guy was trying to save his life. Proceeded to whoop this dude's ass to the point where he was in the Good Samaritan wound up in more critical condition than the guy that was having the opioid overdose. Um, so just be careful with that. The most important treatment you can perform for a poisoning is diluting and or physically removing the poisonous agent. That was kind of the mindset for activated charcoal. The only problem with it, like I said, is that your digestive tract tends to work. It's almost like a train. Everything kind of works in the same pace. So if you're 20 minutes behind the curve on whatever they took, the activated charcoal is probably not going to reach them. It's not going to catch up. So it really doesn't do any good. How you provide treatment depends on how the poison got into the patient's body in the first place. So 4 routes to consider, just like your medicine, right? Did they inhale it? And a lot of times, inhaled poisons aren't recreational. There's not a lot of stuff out there that we inhale as a drug um, that will result in you getting 911 called. The thing that comes to mind the most that I've seen is nitrous oxide, which is basically laughing gas. If you guys go on to advanced EMT, that's a medication you're going to have to learn how to give. It's inhaled. The thing about it is that if you overdose on it, the minute you drop the thing that it is you're inhaling through, be it like a balloon or whatever, you're going to wake up. The stuff wears off in like 30 seconds as soon as you take it away. You're only under the influence of it while you're breathing it. Um, so if somebody's having an inhaled emergency, it's probably something a little bit more longer lasting and not intentional. So carbon monoxide would be an example of that. Absorption, fentanyl patches are an example. Nitroglycerin patches, anything of that sort can absorb through the skin. Ingestion, so anything they ate, it could be anything under the sun for that. And then injection, which again may not have been intentional, right? A snake bite would be considered injection. So don't get into the habit of jumping straight to fentanyl or heroin or anything like that. All 4 routes of poisoning can lead to serious and possibly life-threatening conditions, so take care to treat your patients appropriately. Keep yourself safe from harm. You don't want to be a victim as well, depending on what it is. Again, not everything is intentional. So if it was a snake bite and snake cannot get away and you show up, snake might bite you too. If you're uncertain how to treat a patient who has been poisoned or exposed, then find the container if possible and contact med control. You can also contact poison control, which I think their number is going to be in this. If not, you can always Google. This is 21st century. Nobody's going to yell at you for pulling out your phone as long as it's for work related things. All right, so let's talk about inhaled poisons. Move your patient into fresh air immediately. If it's something that's going to wear off of them as soon as they get away from it, then fantastic. And that's a lot of times that's going to fix them. They may require supplemental oxygen, especially if we're dealing with carbon monoxide patients. And if you suspect it's something toxic, anything outside of the ordinary, say like hydrogen cyanide, for example, call a hazmat team. Right? Let them get there. And if you show up, if those alarm bells are going off in your head from the minute you show up, then maybe it may not be a good idea to run up to your patient. So, keep that in mind as well. CBA is necessary to protect yourself from poisonous fumes. The easiest way to to put that out there is, as firefighters, we don't run into the structure fire without our pack on, unless we're acting in backdraft or something. Um, some patients may need decon by the hazmat team after removal from a toxic environment. The patient's clothing should be removed in the process because it may contain trapped gases that can be released, exposing you to the substance. We also, excuse me, we also don't want to carry a contaminated patient into the ER because that's a confined space as well, right? They're usually well ventilated, but you're still indoors. And if you're dealing with something that's gaseous and inhaled, where's it going to go? So try to get them as decon as you can beforehand. And if it is a hazmat scene, let the ER know ahead of time so they can prepare. The patient may have the following signs and symptoms if it's something along these lines. So burning eyes, sore throat, cough, chest pain, hoarseness, wheezing, respiratory distress, dizziness, confusion, headache, stridor in some cases. Pretty much all of their sinus cavities are going to be messing up, their throat, anything, anywhere that gas can get. You typically don't see things like hives in these kind of poisoning cases just because that's not how it's affecting the body. You're going to see a lot more respiratory issues come out of this. Some patients use inhaled poisons to commit suicide in a vehicle. If that's the case, if that's what you've come up on, where somebody's, the car's running in the closed up garage and they've got a garden hose running from the muffler to the passenger compartment or something, treat it like any other hazmat scene. Open the door, turn off the car, air it out, get your patient out to fresh air, give them some oxygen. Hopefully it's not too late. Hopefully they didn't succeed. Perform CPR if you need to, or if you can. Again, in these cases, usually there may not be anybody around that is going to scream that there's a DNR. They're not going to call you out to help them and then tell you that you can't help them. So be ready if that's the case. You may be doing CPR while you try to clear their airway and get their blood back pushing oxygen. A recent variation involves using chemicals or detergent in a tightly sealed vehicle as a type of gas chamber. When you open the door, be careful because that gas is going to come out and it may get you as well. So if that's the case, you can go in as wearing SCBA, but be aware some gaseous substances, when they're chemically caused like that, if they get into your mucous membranes, even on your skin, they can cause issues. So you may want to call hazmat or the fire department, and they can dress up in their level A suits if they're hazmat tech trained and actually get your patient out for you so that they don't have to worry about that. For absorbed and surface contact poisons, these poisons can affect the patient in many ways. So you have skin, mucous membrane, eye damage, chemical burns, rashes or lesions if it's getting into their skin, and systemic effects, which can be like, in other words, the entire system is having problems, cardiac system, respiratory system, that kind of thing, not just a single organ. It's important to distinguish between contact burns and contact absorption. So signs and symptoms of absorbed poisoning are going to be a little bit more internal. So you might have a history of exposure, liquid or powder on the patient's skin. There could be some burns and itching, but you're going to see more of a deeper effect without the actual burn. Emergency treatment for typical contact poisoning includes, first of all, like it says there, don't contaminate yourself. So scene safety. Remove the substance from the patient as rapidly as possible. And we're going to talk about that a little bit. Actually, I think it's all in this slide. Let's say somebody gets lime on them, or a powdered pesticide or something like that, and they're absorbing it. It's going through their skin. If it's a what's the name, phosphorus based pesticide, it will actually slow the cardiac rhythm to a halt. In fact, we give one of the direct reasons that we would give a patient atropine is to pick them up pick up their heart rate back from that bradycardic rhythm that they're getting into because they've got that stuff on them. Because you see that a lot in farms. Anyway, what we want to do is remove as much of this as possible. Now, we're thinking about this. We're not talking about spending 45 minutes while our patient is screaming at us if they're even conscious and trying to figure out exactly what they got and exactly how it's going to react to water and all that stuff. So these are some pretty much just gross decontamination procedures you're going to do if you ever see this, if it's a powder. We don't know if it's going to react to water, right? If we put a little bit of water on it and suddenly that causes it to um, produce heat, if it's water reactive, we just basically set their arm on fire. And that's a bad thing. So remove all contaminated clothing, flush and wash the skin. Before you do that, if they have any powder still on them, try to brush it off. Just don't use obviously your own bare skin to do that. That would be bad. Get as much of the dry powder off as you can. You don't have to wipe it all off, but just knock the excess. And then when you flush, you're going to flush for about 15, 20 minutes. Just keep running water over it until you are absolutely certain that it is all gone. You don't want to take the chance. If liquid has been spilled onto the skin, flood for 15 to 20 minutes. If a chemical agent is introduced to the eyes, irrigate them quickly and thoroughly. We in the military, we actually put eyesight up there with life and limb. So that's a good example because that's one of your most important senses. You have to be able to see. Hopefully, I mean, yes, there are such thing as blind people, but you want to try to save your patient's eyesight if at all possible. So life, limb, and eyesight. If they've got it in their eyes, absolutely try to get it out as quickly as possible. If it's in one eye, make sure that you position the head so that the runoff doesn't take that into the other eye. Okay, just be a little smart on that one. That just comes down to not getting tunnel vision and freaking out. Because again, if they've got something in their eyes and it's burning like holy hellfire, they're not going to be standing there calmly waiting on you to fix, and they're going to be like clutching their face, screaming bloody murder. It could be it's a really anxiety-inducing issue. It's not; those aren't fun. Like I said, that's not a calm patient, right? So you're going to be trying to shout over them to be heard so that they will follow your directions, because otherwise they're not going to. You can't be soft. They're not going to hear you. They're too busy screaming. All right, we already talked about that. If chemical is in the eye, irrigate quickly and thoroughly. Make the bad eye the low eye. So if it's the right eye, what I was basically saying, if it's the right eye, turn their head to the right. And that way, when you flush the right eye, it just runs off the side of the face. It doesn't run over the bridge of the nose and over the left eye. Many chemical burns occur in an industrial setting. So if you've ever worked in these settings, even fire departments, if you guys should have eye irrigation systems, maybe a one of those industrial showers or something that you can jump under and pull the handle and it douses you in water. OSHA requires those in a lot of places, so you probably have seen them and even just didn't even realize they were there. You as a responder, if this is what you're dealing with, especially if it's on a massive scene, you can get a hazmat team there to assist you. Ensure that you and your team, anybody else is exposed, are thoroughly decontaminated. After decon, promptly transport to the ER for definitive care. And again, let them know that you're bringing them a possibly contaminated patient, even if your decon was successful, just so they can prepare, because there's always that chance that something is still on them, and then some unknowing nurse or a doctor or whoever, maybe the ER tech is going in there to clean them up, gets it on them. We don't want that getting loose in the hospital. You can obtain their SDS, their material safety data sheets, for whatever it is that may be on them. And then if you can't get it in your hands immediately, that's okay. You can always have the company fax it over to the hospital, but it needs to happen fast. Don't let it sit there. Or any knowledge you can bring with you to the ER is better. For ingested poisons, about 80% of poisoning is by mouth. This is usually how you're going to come across patients with poisoning. So liquids, household cleaners like bleach, contaminated food. That's one of the reasons why so much is done by mouth is because of food. Plants and drugs. Ingested poisoning is usually accidental in children, but it's not so accidental in adults. We typically know what we're putting in our mouths as grown-ups, whereas kids will do stuff out of curiosity and they don't know it's bad for them. You know, the 2-year-old doesn't realize that the bleach is going to burn her, but the 30-year-old absolutely does. Signs and symptoms vary greatly with the type of poison, the age of the patient, time that has passed since the ingestion. The further it goes, the worse the damage is going to be. And the signs and symptoms include burns around the mouth, GI pain, vomiting, cardiac dysrhythmias, seizures, ulcers aren't listed, but they can be there as well. Um, if you drink something that's really caustic like bleach, you're going to have legit burns all the way through your digestive tract as it goes, especially if it's not watered down. Say you know the difference between drinking bleach out the bottle versus drinking bleach out of a bucket of mop water. Treat signs and symptoms and notify the poison center and medical control of the patient's condition. If a patient has an altered mental status, you are definitely behind the curve. Protect the patient from aspirating on vomit, and just your normal assessment protocol is what you're going to do for that. But hopefully you get to them before that happens. You really can't slow it down, but if they're already altered when you arrive, that should tell you that, especially if it's ingested, they took it a while ago. Think about what we've talked about with medicine. How long does it take for medicine usually to start to affect you if you take it by mouth? About 30 minutes, yeah, and that's a minimum. Um, 30 minutes minimum is the average, and it can take longer than that. It depends on what it is. So if you show up and they're already affected, that's a major problem. That means that it's already there. You're way beyond having any effect from activated charcoal, um, or anything else. You know, maybe Narcan will help, but any orally taken antitoxin that you can give them is never going to catch up. So keep that in mind. If you do get an activated charcoal question on the registry, like when I remember mine was your patient drank bleach and it was like 30 minutes ago. Um, what are you going to do? And I had the option to give activated charcoal or just, copious amounts of diesel and get her to the hospital and all that. And that was the answer, was get her to the hospital. It was not waste time with activated charcoal because she had taken it so long ago. Um, that's why I try to make sure I always mention that in the class, because I don't know if a question like that still exists on the registry, but it's good to know. Consider whether there is an unabsorbed poison remaining in the GI tract and whether you can safely and effectively prevent its absorption. So that's where you're starting to consider that activated charcoal. Some systems do still use it, but for the most part, it's pretty much it's not it's not bothered with. It's still in the protocols as far as like what we teach. So you need to know about activated charcoal, but the chances of you actually using it in your system are pretty slim. If a patient, oh, I already said that. You should always immediately assess their airway, breathing, and circulation of every patient who has been poisoned. And keep in mind too, your if you're going to give activated charcoal, they have to be able to swallow it, right? So if they're already altered, then even if you think the activated charcoal can catch up to whatever it is they took, you still can't give it because they're going to start to, you can't trust that they will not aspirate what you're giving them by mouth. We can't give anything by mouth to an altered patient. Yeah, okay, y'all. Yeah, see, that's what I'm saying. A lot of places are just they're like it's a complete waste, and it's dangerous. It can choke your patient. Um, you pretty much if you even the systems that do still use charcoal, a lot of them are pretty much saying if you didn't see them take whatever it was they took, don't give it. Like that's how fast you have to get it to them for it to do any good. Um, and you wouldn't have even, let's see, we use it in NBC in the military. Okay, so I'm unfamiliar with that acronym. Is that what's NBC? Oh, okay, so like CBRN, CBRN. All right. Yeah, well, we use it. we don't give it as an ingestible antidote. Our clothes are impregnated with it. So like if we're going to put on our mop gear, for example, and I don't know if that's a different acronym from what y'all use in the Army, but our charcoal covered stuff in case we get anything on us, um, that's where we use it. We don't drink it by any means because if it's something that can get into our mouths, typically we're already masked up anyway. But that's a good point. Yeah, we do. There is still a place for charcoal. It's just the whole, shoving it down somebody's throat. That's what's going away. Exposure by injection includes IV drug use and envenomation by insects, arachnids, and reptiles. Anybody that's ever been down to Texas, especially those of us in the military that go to training there, how often you find a scorpion in your boot when you're getting dressed for the day? That's happened to me twice in San Antonio. Um, it's just, and the sad thing is, happened to my battle. Oh, really? Yeah, that's some scary stuff. Like I don't do reptiles. I don't mess with snakes. I'm never gonna have a pet snake. Um, if it's not warm blooded, I don't want it. I don't want it anywhere near me. Um, and I'm going to put my boot on one morning, and like when I grab it, what this scorpion that decided to make his home in my boot, um, very quickly exited and almost exited right onto my hand, which of course made me shit myself basically. Um, yeah, it's not fun. But anyway, the problem with these kind of poisons, they can't be diluted or removed from the body in the field. All right, there's nothing because it goes straight to your bloodstream typically. There's no by mouth thing that you can give them that's going to dilute that because that's two completely different body systems. The patient's condition can be life threatening, so you must act quickly. Signs and symptoms include weakness, dizziness, fever, chills, unresponsiveness, and excitability, which is fantastic because that speeds up their pulse, which makes it circulate their body faster. Um, you, you're never going to calm them down. You can be like, woosah. Yes, I know you got bit by what looks like a cobra, but it's okay. Just calm down. It'll be all right. Yeah, right. Monitor the airway, provide your high flow oxygen, and be alert for nausea and vomiting. Um, this is one of those signs where if they're going to have vomiting, it will definitely come with nausea. So if you don't see the nausea, be on the lookout for something secondary that may be causing the problems. Um, remove rings, watches, and bracelets from areas around the injection site because they're definitely going to swell. All right, it's only 6:45. We'll keep going. So for your scene size up, again, safety, 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 safety. If it's something that might still be there, you don't want to be victim number two. A well-trained dispatcher can obtain important information pertaining to the poisoning call, including the proper protection needed, information pertaining to their mechanism or nature of illness, number of patients involved, additional resources, and whether trauma is involved. A lot of times, the cool thing is that your dispatcher can get this information for you. The downside is I've never had a dispatcher get this information for me, at least not without me asking for it. Take standard precautions and look for clues that might indicate the substance. Ask yourself the following questions. Is there an odor in the room? Just be aware that if that answer is no, that does not mean that the air is still safe because, again, carbon monoxide doesn't have a smell, but natural gas does. Well, kind of. The mercaptan in it does. Are there medication bottles lying around the patient and the scene? If so, is there medication missing that might indicate an overdose? Usually, if it is, if somebody's going to take a pill bottle full of pills and try to hurt themselves, they're going to take the whole bottle. I don't normally see somebody, pull a bottle of 50 pills out and say 30 ought to do it. Usually, they're going to just take all of them. Are there medication bottles? Well, are there alcoholic beverage containers present? Are there syringes or other drug paraphernalia on the scene? And is there a suspicious odor and or drug paraphernalia present that may indicate the presence of a drug lab? That's common, especially in our part of the country. But like I said earlier, just because you see it don't automatically assume that that is your patient's. It may not be. I remember in college, most of my friends did drugs. I did not, but I hung out with them regardless. If anything would have ever happened to me and somebody came in to pick me up from the ambulance and they see everything around me, they're probably going to assume that I was partaking. So it is what it is. Just try not to get that tunnel vision on it. It is definitely good to note that it's there, because it could have been an accidental injection. Who knows if there's needles laying around, your patient may have accidentally stuck themselves. I mean, who knows? Just don't get that, oh, he's a druggie, and then go from there, because then that will affect your patient care. For your primary, determine the severity of the patient's condition. So AVPU is going to be important here. If you notice that they are altered, that means that you're a little bit behind the curve on trying to stop whatever it is that's messing with them. Get your general impression of the patient. Are they sick or not sick? Get their level of consciousness, determine any life threats, and don't assume that just because they're conscious and alert doesn't mean that they're stable. It could be that they're compensating pretty well, but it may change. Then you move into your ABCs. So for your airway and breathing, be quick. Make sure they have an open airway and adequate ventilation. Again, if they're conscious, then they are fine. Typically, you could just give them oxygen. If they're unconscious, now you've got to start paying attention to whether or not they need an OPA or an NPA. Do you need to bag them? That kind of thing. If the patient may have an inhalation injury, say they inhaled something that's caustic, place the patient on high flow oxygen regardless of the pulse ox reading. This is one of those times where it doesn't matter if they're at 100%, you just give it to them anyway. There's always that chance, and we'll talk about it more in burns. If you ever inhale either something superheated or caustic or whatever, and you start to have some kind of sign of swelling or damage to your airway, the swelling's probably going to get a lot worse. So be ready for that. Be ready for a closed off airway. Call a paramedic because they may need it too. Your OPA and your NPA may be completely ineffective on keeping their airway. Have suction available, and you may have to use a bag. For circulation, assess the pulse and skin condition, and depending on what it is they took, you'll find variations depending. So a lot of times, if they let's say it's alcohol poisoning, you're going to find that they kind of resemble shock. They're going to get cool, clammy skin. They may turn blue on you. I've turned blue before. Got pictures of that one. Because that's what you do. Instead of calling the hospital or calling 911, you take pictures of the Smurf on the floor. Anyway, some medications though, or some overdoses may have the opposite effect. You may wind up with the red flushed skin. It just depends. It depends on what it is. Make your transport decision, which if they have overdosed on something or there's some kind of toxic, if it's not something you can definitively fix in the field, which is very rare, they're a high priority for transport. If there's anything wrong with their ABCs, there's a high priority for transport. For history taking, investigate the chief complaint as always. Start off with why did they call you, and let your assessment go that route. Obtain the patient's medical history. You can do this on the way if you need to, either from your patient directly or you can have a rider. If they're bad condition, don't waste time at the scene. If your patient is unresponsive, begin with an evaluation of the exposure and the sample history if somebody is there. If the patient is unresponsive, I'm sorry, I said unresponsive before. If the patient's unresponsive, you can get your history from other sources. So coworkers, bystanders, next door neighbor, whatever, friends, family. We talk about their medical jewelry and wallet cards, all that's there. You won't ever get all the answers from other people, but you should hopefully be able to get enough that the hospital has something to work with. All right. First person to unmute and answer, tell me what sample stands for. I'll get you started. Signs and symptoms. Go ahead, Crystal.
Signs, allergies, medications, prior medical, last oral intake, and events.
Awesome. And I like how fast you did that. Everybody, yeah, work on that. If you don't know it, if you haven't got it down yet, get it to where you can just rattle it out. All right, so ask him what the substance was. When did the patient ingest it? So how long ago? How much? Pretty much just get those kind of answers. Try to get as much stuff about whatever they took as you can. And then has anybody tried to do anything to help them already? How much did your patient weigh? Blah, blah, blah. We already talked about all those. For your secondary assessment, you may not have time to do this, or at least you may not have time to do it on the scene. It really just kind of depends. But focus on the area of the body involved with the poisoning or the route of exposure. If they got injected or bitten, um, or if there's like a contact absorption, you can focus on that area. If it's something that they ingested, well, the only thing you can really do is assess their airway. Other than that, it's going to be a systemic issue, and you're going to be trying to deal with the whole, respiratory depression or cardiac depression, whatever it is it's causing, whatever their problem is. So your focus area might be CPR. It depends on your patient. Once your ABCs are out of the way in the primary, then you can start trying to do your physical exam if you are able to get additional information. So your head to toe, what do you think you're going to be looking for in these? If you have an unresponsive patient on the ground, it's possibly a toxic issue. What are we looking for when we do their head to toe? We're not looking for broken bones or anything like that. What do you think we're actually trying to find? And sometimes this is a pretty hard thing to do. Yeah, you want lung sounds, but for your secondary, your lung sounds you can actually get in your primary because you're worried about the breathing. So we're talking about there during the head to toe. Nothing? Okay. Try to figure out what it was or where they were injected from. If you don't like, let's say it's a that you don't know what it is, right? They have no idea if they breathed something in, if they got injected or whatever. You can do a quick look in the mouth, but short of seeing damage to their airway, to their mouth, like burns or swelling, you really don't know if they ingested anything. So when you get to your head to toe, make sure you're very thorough when you're looking at their skin to see if they got bitten or stung or any of that kind of stuff. That'll give you clues as to what you need to be worried about. All right, and then get your vital signs. Once you've gotten your vitals, then you just kind of go into your reassessment, which is basically, did anything change from your primary? If you did an intervention, is the intervention still holding up? What do their vitals look like? What's your general impression? Are they getting better, getting worse, or staying the same? And if they are altered, or for any other reason you deem them to be unstable, we're going to repeat your vitals every 5 minutes. If they are stable, say it's like a localized injury, then every 15 minutes is fine. All right, from here we'll take a break. To be back at 5 after 7, and we will continue on with medical care for the different toxic issues that we can run across. All right, let's get back into this. I'm waiting on a text. I may have to put you guys on another break if one of our other classes doesn't stop having technical difficulties, but I think since it's working for us, assuming y'all can hear me, um, it should be working for them here soon too. So emergency medical care, um, first of all, ensure the scene's safe, right? Make sure that you're not going to wind up being a patient as well. Put on your gloves, remove tablets or fragments from the patient's mouth, and wash or burn or brush away the poison from the patient's skin, like we talked about. So basically, we're going to remove anything that's not already um, making the matter worse, because we don't want it to get into their system and then just give you more problems. Your treatment focuses on support for this. So a lot of what I tell you is going to be pretty much the exact same thing. You're going to, patient to or sorry, position to comfort, oxygen, um, keep the airway clear, that kind of thing. Assess and maintain your patient's ABCs, provide oxygen as necessary, treat for shock if necessary, and transport the patient promptly to the nearest appropriate hospital. Some EMS systems allow EMTs to give activated charcoal by mouth. Now, most of them don't. We're going to do a quick run through of it just so that you kind of understand how it works. Activated charcoal is a suspension, so you're going to have to mix it with water or some other kind of liquid to give it to them. You're not just going to push powder down their throat. That's going to cause them to choke. But you mix it up, you make a slurry of it, and then you have your patient drink it. Obviously, if they are altered in some way, you're not going to give this because we don't want them to aspirate on it. Um, and then at the same time, you're only really going to give this if you're very quickly following up whatever it was that they ingested. It's only good for ingested poisons. It's not going to do anything for injected. It's not going to do anything for inhaled. It's so specific and it's so nitpicky on when you give it that most view systems are just gotten away from it. Um, but anyway, that's what you're going to wind up giving it for. If local protocol permits, you will likely carry a plastic bottle of pre-mixed suspension, each containing up to 50 grams of activated charcoal, which is what this slide says. And I give you a couple of different names out there you may see: Actidose, Instachar, Liquichar, or more commonly, No Char. The usual dose for an adult or a child is 1 gram of activated charcoal per kilogram of body weight. So basically, it's 1 pound. I'm sorry, 1 kilogram is 2.2 pounds. So what you can do is take your body weight, cut it in half, and you're at least in the ballpark of what your kilo is. You're a little bit on the lesser side of it. So like I'm 200, let's say I'm 200 pounds. I would say, all right, I am half of that, which is 100, and then I'm going to come just a couple pounds down from there because it's 2.2. Come down a little bit further, maybe like 5 pounds, and I'll say, all right, so I'm 95 kilos. That's pretty close. It's not exact, but it's close enough for what we do as EMTs. Now, when you go to paramedic school and you start talking about things like dopamine, you need to be much closer to exact, much more confident in what your weight guess is. But for activated charcoal, it's whatever. They're just gonna poop it out. It's like taking fiber. You're not gonna digest the charcoal. The charcoal's gonna move through you. It's just gonna pull the toxins with it. So it doesn't really hurt. You just want to make sure you're giving enough. Um, Before you give a patient charcoal, obtain approved approval from medical control, which again just wastes time. That's another reason why they're getting away from it, is because you could just be getting to the hospital. Shake the bottle vigorously to mix the suspension. You may need to convince the patient to drink it because it tastes like crap. I had to drink a balls. I forget what it was called. So it was like a white charcoal. Um, I had to drink it in the hospital one day when I was a kid. And you want to talk about nasty? I was throwing up as much of it as I was drinking, and the nurses were yelling at me because I was making a mess, and they wouldn't let me go to the bathroom. So I don't know where else they wanted me to put it. But yeah, it was bad. And charcoal is no different. It tastes like crap. So It's not, your patient's not going to want to drink it. Not to mention the fact that, especially if they took whatever they took on purpose, they may not want you to help them in general. They may resist you. So it may not have anything to do with the fact that the charcoal tastes bad. It may just be that they don't really want your help. Once the patient is finished, discard the container, record the time you gave it, and get them to the hospital. If the patient refuses the activated charcoal, just document the refusal, and transport them anyway. Some side effects of ingesting activated charcoal are or constipation and black stools. That's it. There's no physical harm, no physiologic harm, as long as they properly ingest it. If you tried to force feed it to somebody with an altered level of consciousness, well then aspiration gets put on the list, and you got bigger problems. If the patient has ingested a poison that causes nausea, um, they may wind up throwing up your activated charcoal. And if that's the case, you have to give it again. For specific poisons, over time, a person who routinely misuses a substance may need increasing amounts of it to achieve the same result. We call that what? Oh, never mind. It's on the slide. Tolerance. All right. So you hear people talk about drug tolerance and things like that, or if you drink all the time, you're going to need more alcohol to achieve your same level of drunkenness or buzz or whatever. A person with an addiction has an overwhelming desire or need to continue using the substance at whatever cost, and that's a lot of times that's the problem. They know it's bad for them. They know it could kill them, but they just have that it's a tug. Um, and it can be a physical thing too, right? We talk about withdrawals. So just saying I'm just going to stop doing heroin or I'm just going to stop doing meth, it's not that easy. It's easy for us if they're on the outside looking in, but for the actual patient, a lot of times they really do need help. They need, maybe not. I mean, you're probably not going to break their addiction. It may take them, if you guys are familiar with Pine Grove, it may take them going there or another drug addiction or addiction in general to kick the habit. Almost any substance can be abused. What's the weirdest thing? You guys give me a story. What's the weirdest thing you've seen somebody abuse? Adderall? Okay. Yeah, I've seen those. A lot of your med students actually will abuse Adderall just because it helps them study. I've seen people drink isopropyl rubbing alcohol because their alcoholism was that far off the rails that the normal drinking stuff just wasn't doing it. Like they could down an entire bottle of Jack and not feel it because the alcohol content to what they were tolerant to was too low. Um, I've seen people try to drink hydrogen peroxide, not for suicidal purposes. They just thought it would give them a high. Um, I know when we were in school, people used to sniff the Sharpies, um, whiteout. Let's see, I saw a guy sniff computer cleaning. Yeah, yeah, and it's because of it's the stuff that's in it that makes it. If you were to flip it upside down and spray it out, it would be really, really cold. That's what they're after. Paint, yeah, paint's pretty common actually. Let's see, I know someone who definitely looked way too much or took way too much NyQuil, like damn near half bottle every day. Yeah. Well, all right. So Robitussin. Anybody remember that? Back before they had to change it, and now you can't buy more than like one bottle at a time or something. Back when I was in school, people used to do this thing called RoboTrip, which basically you would take a bottle of Robitussin and just chug it, the whole thing. And there was a chemical that was in it. I think it was actually the active ingredient, the DXM, um, that would give you a damn near out of body experience, like you were watching yourself in the third person. You really couldn't feel. You'd be numb in certain places, and you'd have that euphoric feeling like you were drunk, but it was more intense. Um, That would, yeah. Well, that's one of the reasons why, like now, if you try to go buy cough syrup, they don't let you buy, is like they regulate it. It was because in the early 2000s, late 90s, early 2000s, that was a fad. You could just, at 16 years old, go into the grocery store, buy every bottle of Robitussin on the shelf, and be high for days. But the problem was is that it was, um, I don't know if anybody died from it, but it was definitely an issue to the point where the government stepped in and said you can't, you can't buy more than like one bottle at a time or two bottles or something. Just like how they kind of regulate Sudafed because Sudafed is so often used in meth. So kind of the same thing. The importance of safety awareness and standard precautions in caring for victims of drug abuse cannot be overemphasized because you're at risk of getting that same toxic overdose as they are, depending on what it is. Known drug abusers have a fairly high incidence of serious and undiagnosed infections, including HIV and hepatitis. HIV, I don't want you guys to be afraid to deal with a patient with HIV. HIV actually is pretty hard to contract on accident. It does not survive outside of the body very well at all. So if they stuck themselves with a needle and it's, let's say they injected themselves with a needle and then 15 minutes later, um, they passed out and then somebody called 911 and then that took you another 15 minutes to get there. Now you're 30 minutes outside of that needle being in their body. There's a pretty high chance that the HIV on it is dead. So even if you did stick yourself, it's not a death sentence. It's not, oh my God, I got HIV. Yes, get tested and follow your protocols for that. But don't be afraid to walk in the room. All right. You're not going to get HIV if they cough on you. You're not going to get it, anything like that. So yeah, it sucks. You got to be careful, but it's not like it's an airborne sickness or anything. Now, where it does become a problem is if they are still combative, because they may bite, spit. If they bite you and they have an open sore in their mouth and they get their blood into your wound, that's different. That's blood to blood. HIV, you have a real high risk of getting it that way. Always wear appropriate protective equipment. Expect the unexpected, and remember, the drug user, not the drug, can pose the greatest threat. Can't expect the unexpected. You can only expect to be surprised. Alcohol. Um, if you live, I won't even say that. Many calls for service have a connection to alcohol use. 1 in 10 deaths among working age adults in the U.S. can be attributed to excessive alcohol use. Alcohol can damage your liver, um, whether through chronic overuse or occasional heavy use like binge drinking. And I'm glad I don't see it on the slide. What is it called? What's that? What is the alcohol-induced disease of the liver called? See if anybody gets it. It's hard to spell. It's not hepatitis. There you go. Close enough. I think there's an H in there somewhere, but yeah, cirrhosis of the liver. Um, Binge use can be more damaging than chronic use, depending on the frequency of the binging and the surrounding circumstances. That's interesting and a little scary. Alcohol is a powerful CNS depressant. It is a sedative, so the more you drink, the more you're going to get sleepy and kind of in that stupor. In general, alcohol dulls the sense of awareness, slows your reflexes, and reduces reaction time. Hence, most of your drunk driving accidents are because they just aren't hitting the brakes when they're supposed to, or the curves in the road. Like I can think of times when I was younger. I used to gauge my drunkenness back in college by looking to my left and then very quickly looking to my right. And if the worlds around me swayed, I knew I was a little too drunk. That's not the best way to go about it. I've learned that as I got older, but I mean, when you're 20, 21, uh, definitely not a day younger, you don't make the best decisions. A person who appears intoxicated may have other medical problems as well. We beat that to death because diabetes can look like drunkenness, but it's not. Look for signs of head trauma, mental illness, toxic reactions, or uncontrolled diabetes. Get you guys to the right slide. Okay. If a patient exhibits signs of symptoms, if a patient exhibits signs of serious CNS depression, provide respiratory support. I mean, that's going to be basically the name of the game for anything you do as an EMT. Your step one goal is always maintain their ABCs. So if they start to get too depressed, you're going to notice that their breathing goes down. It's just like if they were to overdose on an opioid. You want to fight that. So obviously, Narcan is not going to fix a drunk person. So you may just have to bag them. Depression of the respiratory system can also cause emesis, which is vomiting. The vomit may be very forceful, so be careful because they can probably hit you from the other side of the room, or even bloody. Especially if they drink a lot, they may have given themselves a gastric ulcer or something of the sort, and so now you're going to have blood tinged in there with it. Internal bleeding should also be considered if the patient appears to be in shock, and the patients in alcohol withdrawal may experience frightening hallucinations or DTs. So if you've ever heard of delirium tremens or DTs, this syndrome is characterized by agitation and restlessness. I've actually, you see actors on TV when they're playing roles of people coming out of drugs. It's pretty accurate. Fever, sweating, tremors, confusion or disorientation, delusions and hallucinations, and seizures again. I think this says seizures twice. Nope. These conditions may develop after a person stops drinking or when alcohol consumption levels are decreased suddenly. So that's kind of, if you think about it, that's kind of the point of having a methadone clinic for people on those particular types of drugs, is because if you come off of them too fast, you actually cause more harm than what you were doing when you were on it. So what the goal of your treatment is they're going to give you a controlled substance and step your dose down and kind of walk you down from what you were doing before. Um, only problem is people abuse that too. All right, opioids. A narcotic is a drug that produces sleep or altered mental consciousness. All right, we give these as medications, and when they're given and taken as prescribed, there's no big deal, at least not normally. But benzos that we've been giving for years do have addictive effects to them. So that's one of the reasons why we've been getting away from benzos, or at least if we can. Some benzos we don't have replacements for. An opioid is a type of narcotic medication used to relieve pain. So an opiate is a subset of the opioid family and refers to natural or non-synthetic opioids. Opioids are named for the opium and poppy seeds that we get codeine and morphine from. And then fentanyl is actually a derivative of morphine. It's just 10 times more potent. Synthetic opioids include meperidine, hydromorphone, oxycodone, hydrocodone, and methadone. These are things that we make in a lab. Prescription opioid drugs are among the most commonly abused drugs in the United States because they're so easy to get. Some people become physically dependent on opioids after taking an appropriate medical prescription. Again, same thing. We're under the same situation with benzos. They have that effect to them. The death rate from heroin overdose, for example, tripled between 2010 and 2013, up to 44,000 deaths. That was back at the beginning of this opioid crisis. Heroin's not so easy to get a hold of, so that's not really the biggest one that you're probably going to see. The big one is going to be fentanyl, is what we normally run into now in the field. These agents are CNS depressants and can cause severe respiratory depression and then cardiac arrest if we don't treat it properly. Tolerance can develop quickly, and that's kind of the issue. If you take it as prescribed, your body gets used to it. So especially if you started off taking it for pain, that means what you're doing as a prescription isn't fixing your pain anymore. So then you get a little bit more. Now your pain's gone, but now you also have this little urge to take a little bit more, just to get that good feel. Just take the edge off. So you do. Well, now you're tolerant to that. You need to add a little bit more and a little bit more. And before you know it, you were completely hooked on this thing. It's not just bad people that get addictions. Good people can become addicted as well. It's not somebody sitting on a couch one day, at least not all the time, going, I wonder what would happen if I took a bunch of this drug. Usually it starts off as they hurt their back, especially if it's a bad injury where they're not going to bounce back, because then you get depression mixed in with it. before you know it, yes, you are hooked on the drug and you can't really get off of it. Although seizures are uncommon, they can occur. Patients typically appear sedated or unconscious and cyanotic with pinpoint pupils. The reason being is because you have definitely hit that parasympathetic nervous system and kicked it into overdrive. So you basically went to sleep. Um, Principal pinpoint pupils are the most commonly accepted sign of opiate abuse. And if this is what you come across, we use Narcan. That's our go-to. Narcan is a trade name. Naloxone is what we call it. That's not made by a certain company. So if you ever hear, like, say, the AHA talk about naloxone, it's Narcan, but they're using the actual medication name, not the trade name. This is an antidote that reverses the effects of opiate and opioid overdose. The big thing to know about this is that basically what happens is this competes for the receptors that the opioids are trying to attach to. This medication is much more attracted to the opioid receptors that we have in our body. So if you have a little bit of fentanyl and a little bit of Narcan floating by a receptor, the receptor is going to grab the Narcan first, and then the opioid, the fentanyl, can't attach. So it stops that medication from increasing its effects, and then as receptors start to kick out the one fentanyl, and it would normally just grab another one, then it's going to grab a Narcan instead. So now they've got one less receptor attaching to that opioid. And then when this happens pretty much systemically, you can start to pull your patient out of it and they'll wake up. And that's kind of what we, like I said, though, there's a balance to it. We don't want to give them so much that they wake up. Just maintain their respiratory status and then get them to a hospital. You basically are keeping them in a horribly controlled coma, but you're making sure that they're still breathing, that kind of thing. You can give it IV if you have that capability, intramuscular or intranasal. We usually use intranasal as basics, but there are some systems, I know, if I'm not mistaken, St. Tammany Parish, for example, they have a ton of IM doses for naloxone. So depending on the med director, you may be able to use that as well. In many EMS systems, EMTs use the intranasal atomized. This is atomized through the nares into the nasal mucosa. So you'll give half of the dose in one nare and half the dose in the other nare. Should only be used when the patient has agonal respirations or is apneic. If they're breathing fine, then don't bother with the Narcan. Like I said, that's not your goal. Your goal is not to wake them up and go to the Saturday night fights. Place an oropharyngeal airway and ventilate the patient using a BVM prior to administering naloxone, because it's more important that you give them air than it is that you make them breathe on their own, per se. You can actually do just fine bagging your patient if you need to. But anyway, as you give it and their level of consciousness rises, the patient will react to the presence of the oropharyngeal airway. So you're probably going to have to remove it when they start to get their gag reflex back. And if that happens, just switch to the nasal. In some areas, lay people are permitted to administer naloxone. Find out if that has been done. Just because, like I said, you want that balance. And plus, let's say that they already gave a whole bunch of Narcan to somebody and it didn't work. What does that tell you? Do you think yours is more potent and would work better? Anybody still with me? Yeah. Something else is going on. If a bystander gave them Narcan and nothing happened, yours isn't going to do anything either. So it's probably not a opioid reaction. At that point, it could be something completely different. All right, sedative hypnotic drugs. Barbiturates and benzos are easy to obtain and relatively cheap. We do still use these in EMS, even though they're starting to some of them are being phased out. These drugs are CNS depressants as well. They can alter the level of consciousness with effects similar to those of alcohol. The patient may appear drowsy, peaceful, or intoxicated. In general, these agents are taken by mouth, so users often take alcohol with this to boost their effects. Occasionally, the capsules are suspended or dissolved in water and injected, but well, at least I've personally never seen anybody do that, but it can happen. Um, IV sedative hypnotic drugs quickly induce tolerance, so the person requires increasingly larger doses. If you're going to put it directly into your bloodstream, you're going to get hit hard, fast, and then your body's going to try to adapt to it because your body's not supposed to get that uh, far thrown out of whack that fast. So, your second dose may be just as good as your first, but your third and fourth may not be enough. You have to start upping it. These drugs may be given to people as a knockout drink or a Mickey Finn to incapacitate them without their knowledge. So, roofies fall into this category. Generally, your treatment is to ensure airway is patent, assist ventilations, and provide prompt transport. It's the same thing because we don't have anything we can give for this. So you're basically going to do your best to keep their primary keep everything in the primary going. So they're ABCs. Abused inhalants. These agents are inhaled instead of ingested or injected. Some of the most common agents include acetone, toluene, xylene, and hexane. Give me just a second. I'm going to mute you guys. Don't go anywhere. It won't be a long break. And I'll be back as quick as I can. All right, sorry about that. The technical difficulties for our one of our other instructors continues. I think GoToMeeting is having an issue. So if you guys log out and log back in and you start having problems, I don't know what to tell you. I think that they're having some technical difficulties on their end. But anyway, getting back on it, talking about abused inhalants. These agents are inhaled instead of ingested or injected, and most of the time, these are accidental. Some of the more common agents we already talked about. These are found in glues, cleaning compounds, paint thinners, and lacquers. And I've got the hiccups. Gasoline and various halogenated hydrocarbons, such as Freon, can be used recreationally. These are also commonly used by teenagers because, again, they have easy access to it. The effective dose and the lethal dose are very close, which makes these a problem, right? So if they're going to do this recreationally, they're going to do this to get their high. The problem is the amount that's needed to get the high and the amount that's needed to kill you is pretty close of a window. So if you overdo it by just a little bit, you may not walk away from it. Take special care in dealing with patients who may have used inhalants. Even the act of walking may cause a fatal reduced arrhythmia. So put them on the stretcher. Try not to let them do too terribly much and get them to the hospital. Try to keep such patients from struggling with you or exerting themselves in general. Use a stretcher to move the patient, give them oxygen, and transport the patient to the hospital. Hydrogen sulfide. This is a highly toxic, colorless, and flammable gas with a distinctive rotten egg odor. Poisoning usually occurs by inhalation. Anybody tell me where you normally find this stuff? Where are you going to find hydrogen sulfide? As firefighters, we encounter this all the damn time. We just don't even know it. Why do we wear SCBA? Okay, no, that's fine. I was saying, where do we typically come into contact with hydrogen sulfide from? As firefighters, we actually run into it pretty regularly. We just don't realize it unless you've ever been to like a fire behavior class or something of that sort. Yeah, you can get it from volcanoes. It's in smoke. Um, so structure fire smoke, there's a couple of bad things that are in that make it up, right? So carbon monoxide obviously is a big problem. Hydrogen sulfide, hydrogen cyanide, all of that's in smoke. So if anybody were to inhale something burning in a house, a lot of times in structure fires, your victims die to the smoke long before the flames ever reach them. But it could be other things too, right? Any incomplete product of combustion that is non-synthetic in nature can cause it. So you would also run into this. This may be what it is that you run into when you're dealing with people who try to kill themselves with their car. Um, it's part of the exhaust smoke that comes out. Some signs and symptoms include nausea and vomiting, confusion, dyspnea, a loss of consciousness, seizures, shock, coma, and pretty much just cardiopulmonary arrest like death. Once the patient has been decontaminated, management is largely supportive. So monitor their vitals, monitor their respiratory and cardiovascular functions, give them oxygen, and provide rapid transport. Sympathomimetics. Now these are the opposite side of the things. We've been talking about downers for the most part. Now we're going to talk about the uppers. Sympathomimetics are stimulants that basically mimic the sympathetic response of the nervous system, so your fight or flight. These stimulants frequently cause hypertension, tachycardia, dilated pupils, and the problem becomes when they really redline themselves a little too much. A stimulant is any agent that produces an excited state. Some examples include amphetamines, so like meth, phentermine hydrochloride, and amphetamine sulfate. Designer drugs such as MDMA are also frequently abused in certain areas of the United States. These are the things that you're going to run into. These are normally taken by mouth, but they can also be injected. Cocaine may be taken in a number of different ways. It can be absorbed through all mucous membranes and even across the skin. You can snort it through your nose. You can inject it if you want to. There was something we learned about in my last drug awareness class. I'm trying to remember what it was. It was you mix cocaine with something else, and it's got its own street name. I don't remember what it is. But it's almost like drinking a vodka and Red Bull, because alcohol will bring you down, but the Red Bull brings you back up. It's something like that where it counters the effects, so you get that euphoric state, but you're not blowing your heart up out of your chest. Smoked crack produces the most rapid means of absorption and therefore the most potent effect. Acute overdose. Let me get back there. There we go. Acute overdose is a genuine emergency. If this is what you're called out for, they need to get to the hospital as quick as they can. Patients have a high risk of seizures, cardiac dysrhythmias, and stroke. Patients may be experiencing hallucinations or paranoia. So be careful, because if they see you as like a purple-headed 6-foot whatever Bigfoot monster, they may run from you. They may attack you. Law enforcement officers should restrain the patient if necessary. Don't leave the patient unattended during transport. And the patient needs to get to the hospital as quick as can. So give them oxygen and be ready to provide suctioning if they start to vomit or aspirate anything into their airway. Bath salts. This stuff was in the news not long ago. It's interesting that it's already into the curriculum, because this wasn't in the curriculum from before. This is an emerging class of drugs similar to Molly, sold as bath salts to escape the legal restrictions imposed on illicit drugs. So brand names include Ivory Wave and Cloud9. These produce euphoria. They increase mental clarity and sexual arousal. They also apparently turn you into a zombie. Most users of this drug snort or insufflate the powder nasally. This effects reportedly last as long as 48 hours. That's pretty good for a drug. Adverse effects include teeth grinding, appetite loss, muscle twitching, lip smacking, confusion, GI problems, paranoia, headache, elevated heart rate, hallucinations, sudden urge to eat the faces off of people. It's just, this is the interesting stuff that's out there. So if you can keep the patient calm and transport, get them to a hospital. Your safety comes first. So if you need to restrain them, yeah, it's big in Florida. That's where all the news stories, Florida man eats face or something, and it wound up being bath salts. Consider ALS assistance and also consider law enforcement assistance, because they may need to restrain the patient. Some of these patients may require chemical restraint, so your paramedic can come and put them down, basically just knock them out to facilitate safe transport. All right, so it's fitting that it's on election night. Take this with a grain of salt. Marijuana is abused throughout the world. Nearly half of Americans have tried marijuana. THC is a chemical in the marijuana plant that produces its high. It's found in a few things. Inhaling marijuana smoke produces euphoria, relaxation, and drowsiness. It does impair your short-term memory and the capacity to do complex thinking and work. The only problem is, so does alcohol. So take that as you will. The euphoria could progress to depression and confusion. Same with alcohol. With very high doses, patients may experience hallucinations or become very anxious or paranoid, same as alcohol. Reassure your patient and transport with a minimum amount of excitement, which, I mean, if anybody's ever been around somebody that's high, they're not the most excitable people anyway. Like the most calm person I've ever seen was on drugs or on marijuana. Marijuana is often used as a vehicle to get other drugs into the body. That's where I'm going to vehemently disagree. I have not seen studies that said that, but there it is in the lecture. That's why I was afraid that was coming. Several states have legalized the recreational use of marijuana, and others allow for the medical use. It is becoming more and more common. I don't know if it's going to ever get to a point where the federal government allows it again. It used to be legal long before my lifetime, but I don't know. The trend's getting there. It's starting to be debated at the federal level, so that's at least a good thing. Edibles or baked goods, candies, and other food additives that have been infused with marijuana. If your patients, whether they smoke it or if they ate it, I will say that from my understanding, the edible version of the high is much slower, and I don't know. It's almost like they're further into the dumbed down area, whereas smoking it hits them harder, hits them faster, but it doesn't last as long. Um, Ingestion can lead to cannabinoid hyperemesis syndrome, which is where they're just going to start to vomit a whole bunch, characterized by chronic marijuana use and extreme nausea and vomiting. Synthetic marijuana or spice refers to a variety of herbal incense or smoky blends that resemble THC and produce a similar high. There's also, what's the new stuff that's out there? Mojo? That's not what maybe that's not what I'm thinking of. I'm trying to think of a specific thing. It's CBD oil. Anybody heard of that? Yeah, the vapes. Um, a friend of mine just started using them. I don't know. I'm kind of dumb when it comes to it, so I'm definitely not going to try to stand from any kind of instructor standpoint with this. Maybe you guys know more than I do, but it's very close to. Apparently, it's very close to marijuana, but it's not the same. Like it doesn't have THC in it, or at least not enough to pop a drug test, from what I understand. I don't know, but that's becoming more popular because it's still regular marijuana is still not legal on the federal level, and there are still a lot of states that it's not legal there either. And even in the states that it is, just because like Colorado, for example, Colorado State Police is not going to mess with you for having marijuana, right? It's a state, it's legal in the state. Um, but that doesn't mean any federal agents in the area can't still hem you up in Colorado. You're not safe from the feds. You're only safe from the state level. It's kind of right, but not exactly same. Same but different. Well, I tell you what, when we do the boot camp in Pascagoula, school me on it because I'm like I said, I'm pretty dumb to it, but I would like to know. I would like to know more. Is that legal at the federal level? Okay, sweet. I just know that the military still gives you like the evil eye if you even mention it. So, and even back in the like 2008 era when Spice was the big thing, um, I remember we had a guy that was in tech school with me, and they were trying to kick him out of the military because he got caught smoking Spice, but they couldn't because it wasn't in the regs that he couldn't do it. Ah, okay, so there is a big difference there. Yeah. See, like I said, I don't know. I'm not a drug guru. That's more of a law enforcement officer's wheelhouse, not mine. Um, talk about retirement plans when I'm not being recorded, but I can't really do anything right now, so I don't know a lot about it. I just know if I see somebody with an altered level of consciousness, I know what to do with them. All right. So hallucinogens. These alter a person's sensory perceptions, and it's not just their visual, right? You can have auditory hallucinations, things like that, where you think you're hearing things that you're not. So voices in your head, which could be a really scary thing if those voices start telling you to do bad stuff, but you think you don't realize it. Eating somebody's face is probably not the best thing to do with your time. The classic hallucinogen is lysergic acid or LSD. Abuse of PCP is relatively uncommon among young adults these days. PCP was big, big, big back before I was born. PCP is a dissociative anesthetic that is easily synthesized and highly potent. Let me get you guys to the right thing. These agents can cause visual hallucinations, intensify vision and hearing, generally separate the user from reality. A good so a buddy of mine, I got some weird friends. Anyway, a buddy of mine who's actually a cop, that's the best part. He told me about a trip he took before he ever became a cop. So he says that when he was riding with somebody, and when it hit him, the lights from the cars around him started to made it look like the world was melting. Like he actually remembered that when he sobered up. He was like, that was the weirdest, most terrifying thing he'd ever seen, because he really thought the world was ending. And so he started like freaking out. He went from, whoa, this is cool, to, holy shit. And suddenly he's curled up in the fetal position thinking he's about to die. 715 of them. 715 voted in favor of up to 2 ounces. 715 of Mississippians. Oh, okay. Thank you for that. I'm like, I'm not following you. All right, well, that's good, because that would hopefully be enough to make it legal to state. But again, still not legal at the federal level, so keep that in mind. Patients experiencing a bad trip have hypertension, tachycardia, anxiety, and paranoia. Your care is the same as that of a patient who has taken a sympathomimetic, so keep them calm. Provide emotional support. Don't use restraints unless you or the patient are in danger. Watch your patient carefully throughout transport. Make sure that they don't start to take a bad turn on you, and request ALS assistance when appropriate. We're going to take, I think well, I don't know. I'll have to see where we're at. We're getting pretty close to break time, but if we're close, we'll go ahead and finish it out. Anticholinergic agents. These are medications that have properties that block the parasympathetic nerve. So they're not uppers in the sense that they're going to really ramp up your sympathetic. They're uppers in the sense that they block your parasympathetic. The classic picture of a person who has taken too much of an anticholinergic medication is hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. Is that on this slide? Wow. All right. Interesting. Common drugs include atropine, which is funny because we actually give that drug. Benadryl, which we also give. Jimson weed, and Elavil. I don't even try to say that word. Amitriptyline. With the exception of Jimson weed, these medications usually are not abused drugs. People don't abuse atropine, right? I mean, most people don't even know what atropine is. Benadryl. I used to use Benadryl as a sleep aid when I was in high school, but that's a classic case of figuring out what tolerance is because it started off one pill of Benadryl would knock me out. Then I needed 2. Then I needed 3. And when I got to taking 4 at a time trying to go to sleep, that was, I don't know why 4 was a magic number, but that was the point when I realized I probably needed to find another way of going to sleep. But people will do that. Now the good thing about Benadryl is, especially if you're using it by the pill, the lethal dose, the LD50 of Benadryl is like obscenely high compared to what one pill is. So you could swallow a whole bottle of Benadryl. I'm not saying you should do it, but unless it's one of them economy size Sam's Club versions of the bottle, if you took an average bottle full of Benadryl, you're probably still not enough to get to have real problems from it. Some tricyclic antidepressants have significant anticholinergic effects. They also open you up to seizures. Tricyclic antidepressants, we really don't give those very much anymore. You don't see those being prescribed that often because of their propensity for seizures and abuse and stuff like that. But you may still find people that have them. Like There are people that will take an antidepressant as needed. So instead of being on something like, say, Wellbutrin, one a day, every day for the rest of your life, they will take it while they're having the depression. And then when they come out of it, they'll just put the medicine up and they won't mess with it anymore. And then, 6 months down the road, a year down the road, when the depression starts to hit again, they'll be like, oh God, oh wait, I got meds. And so they'll go and they'll start taking the meds again. Um, the only times I've ever really seen problems with tricyclics is, a kid is depressed, kid wants to commit suicide, and kid tries to take mom's tricyclic antidepressants to do so. I've actually been on that call. And the biggest thing, again, the biggest thing we worry about is seizures. So the seizures and dysrhythmias are best treated in the hospital. The best thing you can do is transport immediately and consider getting a paramedic there, because they can go ahead and hook up the 12 lead, um, figure out what the heart's doing, and if they need to give any kind of medication or control a seizure before, medicinally, that kind of thing. Cholinergic agents. These agents overstimulate normal body functions that are controlled by the parasympathetic nerves. These include nerve gases designed for chemical warfare. So now we're getting into acts of terrorism if it's intentional. Some people will try to use this recreationally, but you don't see it that often. Poisoning in this can result in excessive salivation or drooling, mucous membrane oversecretion, runny nose, excessive urination, tearing of the eyes, uncontrolled diarrhea, abnormal heart rate. The gas chamber at basic. I know y'all know what I'm talking about. That's this, right? That's what they did. They light that thing on fire in the middle of the room. They make you do jumping jacks and then take your mask off, and suddenly it's a bad day for everybody. Um, that's what this is. So the signs and symptoms of cholinergic drug poisoning are easy to remember with the mnemonic dumbbells. There we go. So diarrhea, urination, meiosis, bradycardia, emesis, lacrimation, seizures, salivation, and swelling. Alternatively, you can use sludgem, and this is actually the one that I normally see people using. Like our paramedic instructors, they're familiar with this acronym more. Salivation and sweating, lacrimation, which is your tear ducts going crazy on you. Urination, defecation, drooling, diarrhea, gastric upset and cramps, emesis, and muscle twitching and meiosis. So sludgem or dumbbells, whatever you want to say, it's entirely up to you. I normally hear sludgems. The most important consideration is to avoid exposure yourself. Decontamination may take priority over immediate transport, and in many jurisdictions, the hazmat team will provide decon and contain the exposed chemical. We're talking about like not the at this point we're not talking about the gas chamber at basic. We're talking about an act of terrorism where there's a ton of it going around, and it's really affecting you. So that's when you're going to really need the decon team. If you remember back in basic, they just had you leave the room and go sit on like either the ground or some bleachers or whatever. And after about 5 minutes, you were fine. If not a little dehydrated. Your priorities after decon are to decrease the secretions in the mouth and trachea. We want to make sure we keep their airway clear. Provide airway support. Antidote kits may be available. We do carry antidote kits in the military, but civilian side, you really don't always see them. Most common is a duodose auto injector. The kit consists of a single auto injector containing atropine and yeah, I'm not gonna say that. Prolidoxine. Anyway, the atropine picks up your heart rate. So if you're exposed to this and you're starting to get that bradycardic problem where your heart rate's slowing down, those auto injectors are designed to amp you back up. So your atropine picks up your heart rate. If a known exposure to a nerve agent with manifestation of signs and symptoms has occurred, use the antidote kit on yourself. That way you're covered. And go from there. And that's what I was talking about earlier, what we use atropine for, a level you'll see, like if you're in a very rural area, organophosphates. is what I was trying to remember earlier. So if it's pesticides, that kind of thing, a lot of those heavy duty pesticides that people pick up at the farm stores, if they get it on them, they're gonna have these. It acts like a nerve agent. You're gonna see a lot of these signs. So you get ALS out there because as an EMT, we can't give atropine. Atropine is a IV drug. You need a paramedic there for that. All right, take a 10-minute break. Be back at 8:10, and we will continue. We're getting pretty close to the end. We're getting really close to the end. All right, let's finish strong. We only have, well, I missed it. Let's see, something like 10 more slides, if that. All right, so miscellaneous drugs. Um, these are the ones that just don't really fit any of the categories we were talking about before. Accidental or intentional overdose with cardiac medications has become common. Children may ingest them thinking they are candy. Now, when we talk about this, we really think about it from the sense of, say, a beta blocker. All right. That's the kind of thing when we talk about cardiac drugs, it's one of the things we're talking about. You'll find where it becomes a problem when the patient should get a better heart rate. Their heart rate needs to climb, but it can't because they got too much of a beta blocker in their system. A lot of that is controlled. The paramedic will fight that with their drugs. They'll try to fight that off, but there's some supportive care that you can be doing as an EMT, and it's good to know what this stuff, what this looks like, because especially like I said, if you're on a basic truck, you need to know when to call ALS to have their additional scope involved. Children may ingest them thinking they're candy. Older patients may forget and take a second dose of their medication. That happens a lot. Sometimes the symptoms depend on the medication ingested, so really there's no way to like build a list. It just depends. These drugs may cause bleeding, cardiac dysrhythmias, unconsciousness, and even cardiac arrest. Not Tylenol, sorry. Aspirin kind of falls into this as well. Contact the Poison Control Center as soon as possible to kind of figure out what you're supposed to do based on what they've got. You may be ordered to give activated charcoal, but pretty sure you won't be, just because that's the way it's going. Aspirin poisoning remains a potentially lethal condition. Ingesting too much may result in nausea, vomiting, hyperventilation, ringing in the ears. You may also cause a ulcer, which means that when they vomit, they're going to have blood. So you may see some blood tinged vomit. Patients with this problem frequently have anxiety, confusion, tachypnea, which is fast breathing, hyperthermia, where their body temperature is starting to climb up, and they're in danger of having seizures. Overdosing with Tylenol or acetaminophen and medications that contain acetaminophen is also common. I'm guilty of this too. When the headache is bad enough, you really do want to just turn the damn bottle upside down and take whatever's in it. It can get pretty bad. I've, for better or worse, on my decision making, I have gone as far as taking a full gram of Tylenol to try to kick a headache before, on multiple occasions. So if that's bad, then I'm lucky because I'm still here. But I know that, like, for example, and it's not acetaminophen, but ibuprofen. Ibuprofen is another one of those things where it's like we're so familiar with what the prescription dosing is that a lot of times we just jump straight to it, when really we shouldn't be doing that. Among the top 25 substances with the largest number of fatalities due to poisoning is Tylenol. Overdose, unintentional or not, must be treated promptly and aggressively. Accidental acetaminophen overdose is as serious as intentional overdose. It doesn't matter if it was accidental. Too far. So gathering information at the scene is very important. Some alcohols, including methyl alcohol or ethylene glycol, are even more toxic than ethyl alcohol, which is what you normally would drink. Both will cause severe tachypnea, blindness, renal failure, and eventually death. So if you've got somebody who's so far off the deep end with their alcoholism that they're trying to drink isopropyl rubbing alcohol, for example, then it really doesn't take much. And there's what is that? What's that alcohol? Is corn based? That it's not moonshine. It's Everclear. That's like one step removed from isopropyl on its own, right? That's a drinking alcohol, but man, is it strong. Last time I played with that stuff, I made it through the neck of the bottle and I had to slug crawl 15 feet to the bathroom. It took me 45 minutes to get there. Immediate transport in these conditions is essential, right? There's not a lot we can do. We just need to get them to the hospital. Food poisoning. Food poisoning is almost always caused by eating food contaminated by bacteria. The good thing about this is you just let it run its course and you're okay. There are two main types of food poisoning. You have the organism itself that can cause a disease, or the organism may produce toxins that can cause a disease. One organism that produces direct effects of food poisoning is the Salmonella bacterium, which we normally run into with chicken. Salmonellosis is characterized by severe GI symptoms within 72 hours of ingestion, including nausea, vomiting, abdominal pain, and diarrhea. So it's kind of like normal food poisoning. It just takes a little bit longer to hit you. Proper cooking kills bacteria. This is why we don't, you don't want to undercook your chicken, for example. And proper cleanliness in the kitchen prevents the contamination of uncooked foods. And that's the slide we were just talking about. The more common cause of food poisoning is the ingestion of powerful toxins produced by bacteria, often in your leftovers. So, staph, which is what they're talking about there, the staph infection you get in your skin, it's the same problem here. The bacterium Staphylococcus is quick to grow and produce toxins in food. Foods left unrefrigerated are a common vehicle. So, the pizza the next day, if you forgot to put the pizza in the fridge, as much as it sucks to do so, you should probably toss it. Results in sudden GI symptoms, including nausea, vomiting, and diarrhea. This is your typical food poisoning. It hits you within 2 to 3 hours after eating, and it can last up to 12 hours after you ate. And you're going to see more nausea and vomiting at the beginning and more diarrhea at the end as it's passing through your system. The most severe form of toxin ingestion is botulism. This stuff is no joke. If I remember when I was a kid, I learned about this in 6th grade, long before I ever got into medicine or anything like that. This is a nasty, nasty, nasty foodborne toxin, and this is not one you just let run its course. This is one that will probably kill you if you don't take care of it. Botulism can result from eating improperly canned food. The spores of Clostridium bacteria grow and produce a toxin. The symptoms are neurologic, so you're not really so much going to vomit or have diarrhea. It's going to be more like blurring of vision, weakness, difficulty in speaking and breathing. This is usually fatal. Symptoms may develop within the first 24 hours after ingestion or as long as 4 days later. There's another symptom that they don't, well, it's more of a sign that they don't talk about here. I don't see it on the slide, is lockjaw. So if you have a patient that's got botulism, it basically seizes up their muscle. So because if you think about it, like, all right, let's see, just for time, I won't ask the question, but if anybody's ever heard of Botox, that is basically botulism injections. And what does it do? It numbs up the face. People that have Botox, a lot of times you notice their face doesn't move, not as freely as like what the normal face would. If you ingest botulism uncontrolled through your food, the same thing can kind of happen. That's where your lockjaw comes from. It pretty much just seizes up the muscle. In general, do not try to determine the specific cause of acute gastrointestinal problems. It really doesn't matter to you in the field if it's botulism or if it's staphylococcus or whatever. These should be treated the same. However, if you're worried about botulism, then you definitely need to get them to a hospital. But keep in mind, that's the thing that separates it is that they shouldn't be vomiting and having diarrhea. Different kind of lockjaw. But if your food poisoning victim is having neurologic issues, don't waste any time. Get them to the hospital as quick as you can, because that's more botulism route than anything else. If it's nausea and vomiting, diarrhea, those, if it's bad, you're worried about dehydration, that kind of thing, you can take them. If it's just normal food poisoning, a lot of times you just tell them to keep drinking water. Try to drink Sprite, something that they can keep down, whatever, and then let it run its course. Their biggest concern is going to be dehydration because they're losing fluid sometimes out of both ends. But regardless, gather as much history as possible from the patient. Transport them if you need to. And when 2 or more persons in one group have the same illness, you should take along some of the food that you think might have been causing it. So if it's a pizza party, bring a slice of pizza. May not be a good idea to eat it yourself. Also, may not be a good idea to hand it to the nurse you don't like and tell her to eat it. It usually comes back to bite you. Plant poisoning. There are tens of thousands of cases of plant poisoning annually. Many household plants are poisonous if ingested. And it's funny because, like, I remember being a kid and we had oleander bushes all around the house, which looked great. My mom loved them, but she wouldn't let us anywhere near them because the oil from the plant was fatal if highly toxic if you got it in your mouth. So, like if we're out there helping her with the garden, she had a big green thumb and I've got a really good brown thumb. I'm great at killing things. Um, we'd go out there and help her out just to spend time with her and everything, but she wouldn't let us anywhere near the oleander because she's like, no, if you touch this and then you put your hands in your mouth or you don't wash your hands before you grab food, um, that's a problem. That could kill you. And she knew that. She was a nurse. So that's the kind of thing we're talking about here. And that's just one example. Some can affect your circulatory system, your GI tract, or your nervous system. It's impossible to memorize every plant and poison, so don't even try. Um, even if you could, you also have their effects that are different for every plant. You can and should do the following though: assess the patient's airway and vital signs, right, just like your assessment tells you to. Notify the regional poison center for assistance in identifying the plant. If you can take a picture of it, then fantastic. I wouldn't actually touch the plant. Most of the plant poisons are going to be oil based. Take the plant to the emergency department if you can't get a picture of it, or if you can put it in a Ziploc bag and you're using gloves, but swap your gloves immediately afterward, and then provide prompt transport. Irritation of the skin or mucous membrane is a problem with the common household plant called Dieffenbachia. I wonder if that's one of these pictures. Because of course they're not labeled. Anyway, this plant, if you chew it, a single leaf may irritate the lining of the upper airway enough to cause difficulty swallowing, breathing, and speaking. So again, you're going to be fighting with your primary assessment on these patients. Maintain an open airway, give them oxygen, get them to a hospital. There you go. And that's it. Any questions on tonight? While I'm pulling up your pen. You have a question? All right, what you got? You can unmute and talk if you want to.
Okay, I guess my question would be like how we were talking about wash the patient, whatever they have on them and stuff like that. Wouldn't it be wash it off with cold water, knowing that when you use warm water, your skin becomes more porous and is more open to sucking things up?
That's a good point. They don't actually teach that, but yeah, if you can get a hold of cold water, I mean, it would be better for that reason. And a lot of times you're not really going to have hot water anyway. Um, if you've got somebody out in their backyard with the garden hose, the first time you turn it, if it's 90-degree New Orleans, the water that's in the hose may be warm, but normally it's just going to be their cold water. So yeah, that's not a bad idea. It probably wouldn't hurt. It may not make a difference, but why chance it? That's a good point. The plants on the slide we grow them foxglove. Oh, okay. Which one?
Hey, Mr. Robert.
Yes, ma'am.
Okay. The plants like the first one you called out, the mistletoe, the foxglove, the rhododendron, the Joseph weed. We grow all that stuff at the nursery.
Okay.
And some of that stuff is not poison. Because I know they come out with the sumac.
Right.
You can even cook with that kind of stuff. And the elderberries, we grow those, and you use those in your cough syrups and stuff.
It may be that it's in the slide because there's over a certain amount of it can hurt you.
Oh, okay.
That's a good point because like if it's in the cough syrup, for example, remember we were talking about robo tripping like when people
Mm-hmm.
Robitussin. If you take Robitussin as prescribed or as what the label says, you're never going to have those problems. But if you try to just chug the whole bottle, that's when
Right.
it may be the same thing with the plants. You know, the amount you're using when you cook isn't that bad, but if you eat the whole plant, that may be the issue.
Right. But yeah, I know all about these plants because I work at a nursery also.
Okay,
Yes.
cool. Yeah, no, I'm not a botanist or anything like that. So like, a lot of this is I know the patient care side of it, but I'm not an expert on drugs. I'm not an expert on plants or anything like that. So any of the times that we talk about stuff like that, if it seems like I'm just going on through it, feel free to add if I'm missing something you think is important.
Okay, I will do.
All right. Well, your pin for the night is going to be B as in Bravo, C as in Charlie, the number 2, the number 1, and the letter T as in Tango. BC21T. There we go. All right. Any questions? Anything that you guys want to know about? I know we're getting good and well into module 3, but I don't think we're that close to being done yet. So still got time to catch up your quizzes, which most everybody is doing a really good job of. So if not, y'all have a good night, and I'll see you on Thursday.